This program is brought to you by Stanford University. Please visit us at stanford.edu.
Okay, so today, as you know, in the schedule, we tried to juxtapose, observations about how aneurysms grow, why they grow, mechanisms related to growth, ways to monitor growth. And, our very first talk, Frank talked about, how do we measure aneurysm progression traditionally, which are mostly by diameter determinations. And I think, as has been alluded to earlier, there's some limitations to using diameter as a singular indication for both monitoring progression of disease as well as triggering intervention. And I think that the purpose of my talk is going to be just to review some of those concepts briefly. So, as you know, abdominal aortic aneurysms in the beginning and still to some extent are diagnosed on the basis of simply physical exam. And some physical examinations are easier than others. Once a patient's anesthetized, preparation for surgery, it's generally pretty easy to palpate a large surgical-sized aneurysm. However, in an ambulatory environment, it can be quite challenging, and Frank Lederle has actually reviewed this recently, looking at the sensitivity and specificity of physical exam with experienced internists who are blinded to patient status. I think there are 100 consecutive patients, 50 aneurysms and 50 normal aortas. And across the board, regardless of size, the sensitivity and specificity for physical examination determining ultrasound or aneurysm presence was 68 and 75% respectively. And the positive predictive ratio, in other words, if the patient actually, how likely in a fold manner was it that you could recognize that, it was 2.7 versus 0.4 in the situation, a negative predictive ratio. Frank found a significant impact on the body habitus and size in terms of the ability to diagnose an aneurysm. And as I told Frank earlier today, since I was quoting all his data, he should feel free to correct me if I've gotten that wrong. But a break point is about 100 centimeter abdominal diameter, or roughly about a 40-inch waist. Above that, it can be very challenging to recognize an aneurysm. Below that, less so, and that the sensitivity ranged from about 60 to 85% based on the diameter of the aneurysm, from smaller-sized aneurysms to surgical-sized aneurysms. Today, I think it's fair to say a minority of aneurysms are actually diagnosed on the basis of physical exam, simply because of the global ubiquitous availability of cross-sectional abdominal imaging in current medical practice. Ultrasound is quite sensitive and specific for diagnosing aneurysms and has been used, as you've seen in multiple examples today, effectively in surveillance programs. Paul Norman recently reviewed data available for screening studies, a total of 4 pooled studies, 125,000 men. I think this was in the European Journal of Vascular Surgery, and found that availability of screening reduced mortality from aortic aneurysms by roughly about half, an odds ratio of 0.56. They also found, not surprisingly, that screening produced more elective surgery, fewer emergencies, and in general, as was found by a number of organizations, including the Health Outcomes Group in the United States, improved survival at not only the 3 to 5 year interval, but actually at later intervals as well. And there's a substantial body of literature to support screening. As also has been discussed today, however, the progression of aneurysm disease as determined by ultrasounds can be variable and makes it kind of problematic to determine whose disease is actually progressing. And a couple of different references have been made to this point. Paul showed some scatter plots showing different progression of diameters over time. This is a figure from the UK SAT, one of Janet Powell's publications, 25 patients who had the longest follow-up in the UK SAT. Each of these data points is an aneurysm diameter. This is diameter on the vertical axis, and it's years of participation on the horizontal axis. Some of these were 6-month and more frequent ultrasounds, but the point is that the slope is almost idiosyncratic for each patient, and there are periods of time when there's enlargement and then periods of time of quiescence. And so someone was making the point today that rate of growth, I think Frank was talking about that, rate of growth was not predictive necessarily of a patient who's going to need clinical treatment. And I mean, there's abundant evidence from just looking at these 25 patients that that's true. And it's this kind of on-again, off-again nature of aortic aneurysm disease that's one of the huge limitations related to ultrasound management. So this again is Frank's data from the ADAM trial. This was comparing immediate surgery with an aneurysm diameter range of 4 to 5.5 centimeters versus surveillance and surgery at the time aneurysm reached 5.5 centimeters. And actually the VA surgeons group did a tremendous job in this study with an overall surgical mortality in the 2% range, which turned out to be significantly less than what was accomplished in the UK SAT study. But even if you consider the relatively low operative mortality involved with immediate repair, I think there's about a 4.9 year average follow-up with life table analysis out to 8 years. A substantial fraction of these patients never actually needed surgery if they all started at a smaller diameter. In other words, if you just operated on everybody in the 4 to 5.5 range, you would have done a considerable amount of surgery that turned out not to be necessary. There were some off-protocol repairs, but no matter how you analyze this data, there's immediate surgery was not justified on the likelihood that there would be a patient would die from an aneurysm-related death. And in fact, if you look at survival between the surveillance group and the immediate repair group, there was really no significant differences throughout the period of the follow-up. And you could also ask the question, well, if you operate on somebody at a younger age, is it likely that they would do better rather than waiting until they get older and the aneurysm gets larger? And Frank's group found on the basis of their data that the operative mortality was not different. Really remarkably good operative mortalities considering the heterogeneity of the US VA patient and physician population background and training, and that there was really no significant differences in any of the major complications related to the procedure. In other words, there was really no harm outside of the actual aneurysm rupturing itself and waiting to management. And interestingly enough, if you take the UK SAT experience, which has recently been published through 12 years, this curve looks eerily familiar to that was generated by the US ADAM trial. Again, no significant advantage to an immediate operation, and if that was performed, there was a large number of patients who would have had surgery that was never really necessary under the circumstances. And there was an intermediate year report around year 8 in UK SAT that suggested there might be a survival benefit in aneurysm-related mortality. I think that was at this endpoint if you'd had immediate surgery, but by 12 years it turned out just to be a statistical aberration. There's no difference between the two groups. So this kind of gets, but if you consider the nature of aneurysm enlargement as monitored by ultrasound diameter, and then you look at the data from the ADM trial and the UK SAT that are so complementary in terms of their conclusions, even though they're conducted on different continents or organized at different times by different investigators, it's clear that ultrasound, although useful, is not ideal for purposes of determining a need for surgery. So, for example, in both UK SAT and ADM trial, some small aneurysms ruptured. So even though patients were under surveillance, they had a rupture at a smaller size. Probably more worrisome is there was recently a review article in the European Journal of Vascular Surgery that suggested that up to 2/3 of aneurysms detected at screening never actually rupture or require surgery, and a substantial number of small aneurysms actually don't grow from the time they're diagnosed. And as we've talked about, there's been an extensive speculation on exactly what is the rupture risk at roughly 10 per patient year, 10 per 100 patients per year. Is that what it is? Yeah, around 6 centimeters. But there's some consensus that the number needed to treat to avoid a death from an aneurysm rupture is roughly 3. In other words, for every 3 aneurysm repairs, there's 1 patient who has avoided death from rupture, suggesting that, again, perhaps 2 were unnecessary. Again, getting to the issue of the imprecision of diameter criteria as a primary endpoint for surgical indications. So this is one of the facets of our overall research program, both my lab individually as well as our SCORE collaboration here between the SCORE investigators, is trying to identify more specific and clinically relevant endpoints for intervention, both surgical intervention for large aneurysms as well as modifying rate of progression for small aneurysms. And we're going to hear more, and we've heard some already, but we'll hear significantly more tomorrow from David Vorp in particular about stress and failure analysis, trying to determine when you'll have a material failure of the aortic aneurysm wall to get a better idea about what aneurysm is likely to become symptomatic. We have been doing some PET-CT scanning as part of our SCORE project. And interestingly enough, just this month, there's published an article in the Journal of Vascular Surgery. 3 symptomatic aneurysm patients and 10 asymptomatic aneurysm patients underwent PET CT scanning just prior to surgery, and there was a dramatic difference in the uptake of the fluorinated glucose in the area of the aneurysm between the symptomatic and asymptomatic patients, and this correlated with number of macrophages, expression of pro-inflammatory chemokines, cytokines, indices of apoptosis, as well as other markers of inflammation and disease progression. We're not looking at symptomatic aneurysms within our SCORE cohort, and I have to say it's kind of the data we have available so far in the smaller aneurysms is underwhelming, but this type of functional imaging study might separate the 6-centimeter aneurysm that won't need to be repaired for 5 years versus the one that needs to be repaired, within 5 days. And I think that's kind of what we need some help with. As far as progression of small aneurysms, Paul talked about some of the limitations of biomarkers, and I guess the only conclusion we can make from that is obviously they're going to have to be considered all at the same time altogether, the relevant biomarkers. And I know other groups are doing this as well, but our SCORE project includes a proteomic profiling component where we're trying to look at the changes, relative changes in protein expression of many what we think are relevant proteins that are present in the blood in patients who have aortic aneurysm simultaneously to look for patterns that might predict evolution of clinical disease. And then our own particular interest, which is the focus of this talk, is pathogenesis imaging. So the challenges to monitoring early disease, if we take a step back from surgery now and just think, if you know you have a 3.1 centimeter aortic aneurysm, and if you know normal growth rates being what they are, you have 6 or 7 years or more before you actually may need surgery, what should you do? That's somewhat made more challenging by the fact that, as Charlie pointed out, almost every small aneurysm is different. This is a 3-centimeter aneurysm, as is this is a 3-centimeter aneurysm, as is this a 3-centimeter aneurysm. And what about those aneurysms do we actually monitor in terms of progression of disease? We've talked a little bit in our SCORE about how, and Tim Baxter's interested in this as well as ultrasound just shows a single diameter, maximum diameter, whereas if we can get volume rendering from a CT scan, then we're more sensitive, we can be more sensitive to changes. But it's not practical to use CT scanning to monitor every patient with small aneurysms outside of a research trial. And in fact, this is still indirect in the sense that it's not really the enlargement of the aneurysm which is defining the progression of disease, it's what's actually going in the wall. And also, if we're going to treat those patients, there may be periods of time, as indicated by those changing slopes on the UK small aneurysm trial, when more therapy needs to be provided or less therapy can be provided or different types of therapy should be provided based on what's actually going on. And I think the whole problem here is the fact that monitoring diameter isn't really monitoring disease. It's not really looking at precisely what's going on in the wall of the aorta. And this also makes problematic how to decide how we're effectively treating disease. So we've, in conjunction with Mike McConnell, who unfortunately had to step out, but is our imaging core director for the SCORE project. He's back. There he is. Hi, Mike. So there you go. So again, Mike can correct me if I'm saying anything wrong, but we're working on functional imaging to kind of get a better sense of what's actually going on within the wall of the aorta. And just some examples of work that's been done in my laboratory recently. We've been looking at markers of adventitial neovascularity as evidence of progression disease, and we've also been looking at imaging studies that can actually visualize MMP activity in a 3-dimensional sense, so we can actually see when MMPs are active and where they're active and how they should be treated to try to affect that. The neovascularity is based on either fluorescence imaging of VEGF receptor expression or targeted antibody microbubbles to VEGF receptors. So it seems as though development of new capillaries in the adventitia as a consequence of inflammation is a recognized component of the pathophysiology of aortic aneurysm disease. And there's some evidence, both experimental from our laboratory, published in ATVB in 2004, as well as human studies in ruptured aneurysms or symptomatic aneurysms, that the density of these neovessels in the adventitia is a rough marker of progression of disease, as an alternative, for example, to diameter. So this paper, for example, showed that there was more neocapillaries in an aneurysmal segment of the aorta compared to a non-aneurysmal segment. And this paper showed that in the area of a rupture, in a ruptured aneurysm, the actual rupture foci or area of actual rupture itself had a higher capillary density than other non-ruptured areas of the aneurysm. So this is immunostaining showing really dramatic receptor expression of VEGF in the section of the aorta in the angiotensin II ApoE knockout model away from the area that's actually ruptured. In the intact portion, and this is co-staining has demonstrated this is in areas of smooth muscle cell, as compared to the same animal in areas where it's non-aneurysmal aorta, much less expression, suggesting that something is happening in this section of the wall related to this growth factor receptor expression that's related to this progression of disease in this area. So we've done some inhibitor experiments with angiogenesis inhibitors that were kindly donated to us from Exelixis Pharmaceuticals in South San Francisco. This particular experiment, this angiogenesis inhibitor has a wide range of growth factor receptors and angiogenesis receptors that it's active against. These are nanomolar concentrations, so it's not necessarily VEGF specific, but this just gives an example of the appearance of a saline-infused angiotensin II treated ApoE knockout mouse model versus animal treated with the angiogenesis inhibitor and then doxycycline as a positive control. And as you can see, the effect of the angiogenesis inhibitor is quite dramatic and similar to what you see in doxycycline. If anything, better preservation of the elastin, although we didn't really quantify this, but significant inhibition of aneurysm progression. We can see this on the basis of CD31 cell density within the wall of the aorta, saline versus doxy versus angiogenesis. So even though the doxy was effective in preventing aneurysm enlargement, there's still more neovessels present in the doxycycline-treated mice than there is in the angiogenesis inhibitor-treated mice. And in terms of diameter, both the angiogenesis inhibitor and the doxy were effective at preventing progression. This work, by the way, was done by Dr. Maureen Tedesco, who's a postdoctoral fellow in my lab, just finished in July after 3 years, and this was presented at the ATBB meeting in April 2007. So because this kind of work had suggested to us, in addition to the clinical data that's already available, that VEGF receptor expression was relevant to disease progression based on the fact that it's present in humans and inhibiting it can inhibit progression of experimental aneurysms. We've looked, for example, at fluorophore imaging of receptor expression. This is using Cy5-5, a single-chain VEGF, and you can see that there's a concentrated fluorescence in the area of the aneurysm compared to animals that are not treated, don't have aneurysms, and also compared to areas of the aorta that are not, in fact, aneurysmal. Although, unfortunately, under these experimental conditions, the animals had to be eviscerated to actually distinguish the fluorescence. We've also used near-infrared imaging with a different optical system, and again confirmed that aneurysms are consistently show significant uptake in this fluorophore compared to either controls that don't have an aneurysm or aneurysms that are injected with inactive tracer. And again, this is the Cy5-5 fluorescence comparison between aneurysms, remote segments of non-involved aorta in aneurysm mice versus control aorta versus those injected with inactive tracer. And in fact, it does appear that the diameter correlates to a certain extent with the amount of fluorescence and receptor expression that's present. These round circles tend to be the control mice, and these diamonds are the aneurysm mice. And there's, you know, not a one-to-one, but a reasonable correlation between aortic fluorescence and diameter, and suggesting that this might be a way to actually look at the disease rather than the consequence of the disease in terms of what's happening within the wall itself. So Maureen has also more recently done some work with receptor label antibody VEGF2 receptor antibody labeled microbubbles, which can be used as an ultrasound contrast agent, again using the Vivo 770 visual sonic system that Alan talked about earlier this morning with this spatial resolution. And it's pretty simple experimental setup here. They have a lipid-based microbubble. It's 2 to 3 microns in diameter. They use strepavidin binding to attach the antibody to the receptor of choice. In our case, it's VEGFR2. And when this is expressed on a target cell, we actually see some localization of that microbubble with this high-frequency ultrasound imaging. This actually is a movie, but I didn't record it as a movie. Here's an aneurysm that we see typically in the APOE knockout model, 2.2 millimeters versus control aorta, approximately 0.8 millimeters. This was the study design. So animals bolused with these microbubbles begin imaging after about 10 minutes. We get a bound and circulating signal, can quantify the amount of microbubbles in the area of focus for the ultrasound. It's then subjected to a disruption pulse, which removes the bound signal and left only with the circulating signal. And the difference between those two then becomes a molecular signal. So you can figure out how much expression there was based on subtracting these numbers. So this is bound and circulating, this is destruction pulse, this is circulating, and the difference then is a molecular signal. Again, a more direct way to visualize what's going on in the aorta in a semi-quantitative fashion. In control aorta, reassuringly, there was no difference between bound and circulating microbubbles and circulating microbubbles. And as fortunately for us, it does appear to be significantly different, even with the small number of animals, between aneurysmal VEGFR2 expression, control VEGFR2 expression, and then IgG antibody, and then IgG with either an IgG in control or in aneurysms as an additional control. And Maureen actually presented this data at this year's ATVB conference. The final modality I want to talk about in this regard is the fluorescence molecular tomography. A company called VisN makes what they call MMP Sense, which is an activatable bioprobe capable of imaging protease activity, and they're constantly coming up with new probes. Currently, they have probes active against MMPs 2, 3, 9, and 13. And this provides quantitative imaging as well as three-dimensional localization of the fluorochrome concentration in vivo. And in general, there's a linearity between expression and activity related to this modality of imaging. This is a pretty basic study design. We use the angiotensin II infused APOE knockout mice and injected this MMP Sense at day 6, and then did imaging and sacrifice at day 7, and then we also injected day 13, did imaging at day 14. And this is basically what we see with this stuff. If we take a cross-section of tomogram of the abdominal aorta, and this is with the intact abdomen, unlike the Sci-Fi 5 study, this does not require evisceration. Actually, just put the animal in the imaging chamber and turn it on. And actually, our friends at Genentech have one of these units too, and they're also working on this as well. We can actually see an area of active MMP activity in a mouse with an aneurysm versus a section of the aorta that is not aneurysmal, has no MMP activity. In a coronal slice, we can kind of localize that as well. And the signal intensity does correlate with the activity of the MMP that we can demonstrate, for example, on a zymogram. And the increased expression, we think, is in fact relevant in terms of the rate at which aneurysms are enlarging. For example, in our experience in this particular study, using serial ultrasound surveillance, aneurysms seem to be enlarging more rapidly at this time frame than they are at this time frame. And it may be then that we have a better idea of what's going on within the metabolism of the aortic wall itself. So just to wrap this up, today, depending on whether we're talking about a man or a woman, indications for surgery still are pretty much limited to the actual diameter determination. There is, I think, an important clinical need to refine these guidelines based on emerging information from stress analysis, as well as potentially some combination of biomarkers, as well as understanding inflammatory milieu related to the aneurysm. One imperative for this is there are developing new treatments for early disease. In this meta-analysis that Frank and I were talking about in an earlier question and answer session that Janet Powell had done that was published recently in Annals of Surgery, one of their conclusions was it appears that patients on statins on the basis large meta-analysis cohort were roughly 50% less likely to undergo rupture of an aortic aneurysm. And so that type of indirect evidence exists, but for us to really move from indirect to direct, we need better endpoints. And it'd be, for us to really decide whether these treatments are going to be effective, we have to really have a better monitoring capability. And in fact, direct monitoring should guide early treatment. And we're hoping that functional image will catalyze translation of promising experimental data like we've seen in a number of animal models to effective clinical therapies. So this would be important to make sure everybody gets acknowledged that's been doing this work. As I mentioned, this is primarily the 3-year effort of Dr. Maureen Tedesco in our laboratory. Dr. Jeff Schultz has taken over that project, as well as Dr. Monica Duo. We've had a number of postdoctoral fellows working in the laboratory recently, as well as in more distant past. And the molecular imaging facility here at Stanford is absolutely spectacular resource for doing this type of work, and has been extremely helpful in terms of helping us design, troubleshoot, and interpret these experiments. And this work, as most of you know, is funded by the NHLBI as well as the American Heart Association. Thank you for your attention. So I think we have time for a few questions, if anybody has them. Yes?
Thank you. Beautiful talk. I just had a question that concerned, how optimistic are you about bringing molecular imaging to clinic? As clearly you showed that currently with ultrasounds there's a lack of information. However, I keep on hearing cardiologists and people that are saying that, I mean, MRI, molecular imaging, PET are really expensive, and they do not plan on doing screening with those modalities, obviously.
Right. Well, of course, there's identifying the signal, and then there's figuring out what's the most cost-effective and clinically relevant way of recognizing it, right? And so those could be two separate processes. Maybe, Mike, do you want to comment on that a little bit?
Sure. I mean, I think you've hit it that at this stage, trying to find really what's the most predictive marker has been the most challenging. I mean, similar to what we heard about biomarkers, even from an imaging standpoint, you know, what is the best thing to try to identify that's going to be predictive of progression or rupture? And so I think it's almost more of the biological understanding of what should we be focusing on in imaging, and then it becomes a technology challenge of how to find an imaging modality that could show that biological activity in as cost-effective way as possible.
So as to Paul's previous comment, so I showed what worked. I didn't show what didn't work. And we've tried using USPIOs with MR imaging and found that, and Joan's here somewhere. Joan? There's Joan. Joan spent a long time on that project and was really unable to make that work in these animal models. And there have been a variety of other dead ends. So, I mean, you know, the big idea is actually image the disease, and how we get there is, you know, it's a process in and of itself. But, you know, there's obviously other applications for this in cancer as well as occlusive atherosclerotic disease. So we don't necessarily have to carry the ball all the way down the field. We just have to be ready to take the lateral when it's coming our way. So, so that's where we are with that. Any other questions at all? Yes, in the back. Dr. Petey?
Yes, so great stuff, wonderful talk. So if I understand correctly, you're showing a lot of VEGF-R1, R2 proliferation and
receptor expression, yes.
Receptor expression,
yeah.
And concomitant capillary perfusion. Are you at the point yet where you can say that the capillaries that you're seeing are mature? Are they actually perfused? Is anything going on in them?
Well, we're talking, you know, very small vessels in very small animals. So we haven't actually looked at the flow in those vessels. We extrapolated their relevance from the available human clinical data. That's been our observation as well as others. I mean, if you're talking about why the capillaries are actually related to the progression of the disease, I think most people feel it's a secondary consequence of the inflammation. The pathologic features that are, you know, kind of pathognomonic, if you will, of aortic aneurysm disease are smooth muscle cell apoptosis, macrophage monocyte inflammation, progressive loss of elastin with kind of ineffectual elastin collagen remodeling, and increased deposition of collagen, which turns out to be relatively ineffective compared to the baseline collagen configuration, and then this proliferation of these neovessels. And it's those four things that are most commonly found in human aortic aneurysm. So we're not really at the stage of actually understanding the pathologic consequence of the proliferation of those neovessels. We're just trying to use that as an indirect indicator of the progression of the disease. But, I mean, there may be something there. I don't know.
Yeah, well, it's not exactly where I was going, though. What I was thinking is new capillaries can't become mature, can't be perfused unless they can proliferate their own smooth muscle. Mm-hmm. And that's in the context of a condition in which smooth muscle is undergoing showing apoptosis. So
Yeah.
that doesn't seem like it makes a lot of sense.
Don't know. I can tell you is that, I mean, there's different ways to interpret that. Which vessels are actually expressing the receptor? Turns out that our immunolocalization studies suggest it's actually the smooth muscle cells. So we're not actually seeing new capillaries in this experimental construct. We're actually seeing smooth muscle cells express the VEGF receptor. And there's other data in the smooth muscle cell literature to suggest that happens under other circumstances. So it may be that in trying to actually image the neovascularity, we're actually imaging some other consequence of the disease process that happens to be going on in the same area that also involves VEGFR2 receptors. This paper has been in editorial review in ATVB for many months now, and we're working on, submission version 3. And the number one critique about that is this disconnect between what we see histologically and what our presumed mechanism is. And then the other issue is is it VEGFR1 or R2 receptors or some of both, or exactly how specific is this imaging modality? So, I mean, those are important questions. I don't know the answer. I'm just suggesting this could be a potentially useful imaging modality.
The preceding program is copyrighted by Stanford University. Please visit us at stanford.edu.